Hi, everyone, and welcome. I'm Shelley Gunther, sonographer and clinical marketing manager here at Clarius. Very nice to see you all here for today's live webinar, Reimagining MSK Education, Teaching Ultrasound for the Next Generation of Clinicians. Today, we welcome physical therapy experts and educators, Dr. Mike Voight and Dr. Chris Wolfe, to share why they decided to incorporate wireless ultrasound into Belmont University physical therapy curriculum and how they made that happen. We'll get a behind-the-scenes look at how Belmont is equipping students with ultrasound skills from day one. Our webinar team had the pleasure of spending a day with Drs. Voight and Wolfe and their enthusiastic students at the Belmont campus and observe how they teach ultrasound and how they learn. And I have to tell you, it runs like a well-oiled machine. Now, you're among just under 1,500 MSK ultrasound enthusiasts who registered for today's event. Good morning, good day, good evening, depending on where you're joining us from. Now, just a quick housekeeping note, please use the Q&A box at any time during the webinar, as we'll have a live Q&A session following the presentation. And we'll also have a little live scanning session where I'll demonstrate a feature called T-Mode for you. I'll be hosting today's event, so let's get started. We'll start off with just a couple of papers here. And this first one is great clinical commentary from the International Journal of Sports Physical Therapy. The authors include our guest speakers today. Now, it provides a framework for why MSK ultrasound matters in physical therapy education and patient care, and offers clear examples of applications across diagnostic, rehab, interventional, and research uses. Perfect for curricular planning. The authors highlight the need for training and institutional support, which aligns well with several insights on barriers to integration. And in this next paper, the authors present a structured framework to support MSK point of care practice, specifically within physiotherapy. Now, it addresses the scope, education, competency, and governance to facilitate safe, consistent integration into clinical settings. The authors offer a comprehensive template for integrating MSK focus into physical therapy education and clinical operations. And it's particularly useful as a reference model for institutions and educators developing MSK ultrasound curricular or building institutional infrastructure. And while detailed guidance in this paper is specific to the regulatory and professional situation in the UK, it provides a really great illustration of how the framework approach can be applied within MSK focus more widely. All right, so just before we get started, we'd like to just do a quick poll. What is your biggest challenge with integrating ultrasound into MSK education? So I'll just give you a couple of minutes to respond here. Great, and we'll close the poll in. Still got lots of responses coming in here. Great. So, okay, so let's close this in 3, 2, 1. Great. Okay, so a lot of you are saying that there's limited training opportunities here and a lack of access to ultrasound equipment. All right, I'm sure you're going to find this presentation really interesting. So let me introduce our guests. Dr. Chris Wolfe is an associate professor in the School of Physical Therapy at Belmont University. He brings over 2 decades of clinical and academic experience focused on orthopedic physical therapy and education. His research interests include clinical reasoning, sports rehabilitation, and the integration of ultrasound physiotherapy curricula. Dr. Wolfe is a passionate educator, I can vouch for that, and an advocate for advancing MSK diagnostic skills in student training. And Dr. Michael Voight is a tenured professor in the School of Physical Therapy at Belmont University with over 30 years of clinical and teaching experience. He's board certified clinical specialist in both sports and orthopedic physical therapy and has worked extensively with professional and Olympic level athletes. Dr. Voight is internationally recognized for his contributions to movement science and sports medicine and is a leading voice in integrating diagnostic ultrasound into rehabilitation education. Gentlemen, I will hand the presentation over to you.
Well, Shelley, thanks for having us. This is going to be fun. It's good to see you again. It's been
You
a while
too.
since you visited. We enjoyed that day we got to spend together. So thanks for having us today.
That was great.
Yeah, great to see you, Shelley. Thank you again. And love that poll because I think at some point we would have really, Mike and I would have been able to answer some version of that question as well. Probably check every single box.
Yeah.
But today we're talking about reimagining musculoskeletal education, and not just like in the clinical setting, in an academic setting where Dr. Voight and I actually teach, but we both have clinical practice, and we do that currently right now. So we really enjoy showing how we move things from the clinical classroom into a clinical practice because we've kind of lived on we're living in both worlds right now. And so today, really what we're hoping to kind of talk about is really like the training gap, like where it is within education and how does that look in clinical practice as well. What are current clinical practice demands of today? Because we know that education is currently evolving and changing. Clinical practice evolves and changes. Modern medicine is evolving and changing. What does educational innovation looks like? We have to continue to evolve with the moving times. And how are we attempting to do that? How are we attempting to pilot that a little bit? And what are we learning from maybe other universities as well that we're partnering with? And then just what does it look like to get started in clinics and in academic programs, which is really kind of what I took away from that poll just now of just others having difficulty learning like how to utilize it and then how to get access to equipment as well to utilize it.
Well, I'll get us kicked off here a little bit when we talk about the gap or the current deficiencies that are out there. And I think if you look globally, and we have medical training programs lack sort of this comprehensive MSK ultrasound education. It's all healthcare providers are looking at this. And I think looking at the problem or trying to define the problem, one of our colleagues, Nathan Savage, did a paper recently. It was a sort of a Delphi project polling physical therapy programs looking at it. And there was some interesting, while the return wasn't as high as we might have expected to see on this, he found some interesting information within. And as you can see, some of the information I put up here in that bullet point, that about 70% of the programs polled, so I'm talking about physical therapy education programs, about 70% said they had ultrasound education or ultrasound imaging within their curriculum. Now, it needs to be broken down a little bit because when you define how much time you put in there, it's a whole different animal. And about 91%, little over 90% of the programs surveyed had less than 10 hours of education in this topic area. And again, that was a bucket list number you could work out of. It could have been 1 hour, but certainly 10 hours or less is a minimal amount of this. Now, interestingly enough, that when we looked at it and said, well, what are the barriers? Well, why aren't they? And it's going to be a theme. We're going to hear this theme, I think, from the poll that Shelley just did. And Chris was alluding to here a minute ago, that about 80%, 79% of the people in this program said, well, why didn't you expand this? It was because of a lack of qualified instructors or a knowledge base to teach this material. And secondly, access to equipment or equipment costs. And we'll touch on that in a little bit with this. However, having said this, this is a big emerging area because even when this poll was done, at least 50% said we believe that this is entry-level education going forward. 44% of the program said we're going to expand our ultrasound imaging components secondary to the expansion of scope of practice. And that's emerging rapidly around the country as states are deeming that ultrasound imaging or using ultrasound in clinic is definitely within the scope of practice of physical therapy. I just got an email this afternoon that just came in that the state of Oregon just ruled that it's definitely within the scope of practice to use ultrasound imaging. And we certainly have that here in Tennessee. Just one last thing about the deficiency, as I would say, is, so I'll defend our own profession with physical therapy. These results are very, very similar to what's out there in the literature relative to medical school education. as Shelley knows, when she came to visit, we have a medical school here on campus and we work closely with our radiologists over there. But it's the same thing across the board, I think, with the barriers of, because we've got an emerging technique of experience and then trying to get the equipment. Having said that, Chris, you want to talk about clinical impact?
Yeah, well, we typically find that not only is the gap in the educational side, and we see some of the deficiencies there, and that's going to trickle into our new graduates or even experienced clinicians as well in the clinical setting. I think that's really what we were just discussing, and again, seeing and visualizing through like the poll we just took. Like, how do we, if we're not learning it in our educational system, then it's going to be really slow to implement that a little bit, maybe in a practice setting. And so being in a clinical practice right now, the patient impact for that is going to be felt, especially because modern medicine continues to evolve. So what are we typically seeing? We're seeing, maybe an increased dependency, more like more of an expensive imaging, because the gold standard is definitely MRI, and that definitely needs to be utilized. But we also know that there's a wait time for that, the cost that is equated to that as well. There's such a good need for diagnostic ultrasound that so many good physicians are utilizing in their practice, and being able to scan and educate our patients on maybe the severity of certain injuries or the progress that is seen through treatment is so important. And it allows, I've seen it actually kind of decrease a little bit of that need or that dependency on a little bit more of an expensive imaging as well. Again, diagnosis and treatment, being able to have a little bit more confidence going into looking at the diagnosis, how it's progressing, how it's healing, or maybe how it's being delayed a little bit. Being able to use it as a visualization and educational tool for patients has been so powerful. And the compliance of plans of care, return visits have definitely shown to be improved because of that as well. And then again, when the patients get caught in, delays from one expert to another, and they're waiting for maybe an imaging, and there's time in between, we know satisfaction rates drop tremendously. So that's really what we see, kind of reduced care efficiency and satisfaction rates, because we're just kind of waiting around really for, can I get a scan to see, is this tissue healthy enough for me to load? Is it healthy enough for me to kind of progress into your treatment, in addition to my clinical assessment?
I think that kind of brings us back, Chris, to sort of this, the SWOT analysis, barriers and strategies. And we just hit on a couple of them. And I think the poll falls right along with the barriers. And we're quickly looking at those. But the biggest ones that were kind of on there that I thought it was a good chunk of people said today, faculty training and experience. And I might want to add to that, that was interesting in the Savage paper that, and I think this adds to your expertise in using MSK ultrasound, is that the schools that do have laboratory experience or have experience with ultrasound, while they said that the barrier was the faculty training or knowledge, very few people in academia were actually using the tool in clinical practice as well. And I think with Dr. Wolfe and I, this has become, it maybe started in the classroom or parallel classroom clinic, but we use it in both sides from a clinical perspective, which is good to bring things back to the classroom. But faculty training's been identified and knowledge of the areas of barrier. Curricular fit, I think the new term for that with accreditation standards is curriculum bloat. You have so many things you have to teach, but what am I going to add? If I'm going to add something, I can't keep adding more credit hours to a curriculum. So something's going to have to come out, or we're going to have to get creative ways to add things. And we might get to that a little bit later on with what we've done here at Belmont to get it into our curriculum, because we have about 30 hours-ish of hands-on ultrasound. Lesson resources, equipment costs, or space, financial, those are all barriers. But I actually think those barriers are getting dropped. They're coming down. Working with manufacturers and working with the different equipment sources, things are happening rapidly where costs are not the barrier anymore. And looking at, I can remember getting started with the bigger units in ultrasound. You're looking at tens of thousands of dollars to get into one unit, let alone multiple units, and different sound heads were thousands of dollars. Now we can get into these units, that's handhelds, that are much more cost effective for not only the clinic, but for teaching as well. So I think strategies that you're going to hear us talk about that are out there, I think all these things are ongoing. And I would say probably the biggest one is that, again, it was that 79, 80% of the people in the polls are saying that it's knowledge or expertise. Some of this is just hands-on training and faculty training. In fact, there's a group of individuals working through the Ortho Academy of APTA and with the POCUS Academy with Atelios. We're actually working on a program right now as we speak on developing a blueprint, a curricular blueprint that everybody can use in education. It's going to be free to get out there. And the idea being that with this curricular blueprint, there'll be there'll be sample curriculums. We're not saying this is the only way to do something. But what we are saying is, if you really are interested in incorporating ultrasound into your curriculums, here's things you could do or strategies you can do. We will give you turnkey tools. You modify them as you need for your curriculum. So I think the training, the resources, the PowerPoints, the labs, all those things are coming to fruition. Even with the POCUS Academy for students, they've dropped the cost down significantly to get students involved early in the process, at least to learn the fundamentals of diagnostic ultrasound. Then I think there's grants and other certifications out there. So while there are certainly barriers, everybody identifies the barriers. The good news is there's a whole group of individuals out there working in this area, this specific or niche market area, that are trying to knock those barriers down. And strategies are emerging every day where it'll make it easier for clinicians to add this and educators to add this into curricular models. I don't know, Chris, you want to talk about practice side of this, the demands?
Yeah, because what modern practices demand, not only are we learning that from the educational side, it has to evolve, it has to keep up because we need to have more of a holistic mindset anyway. And I think most people are agreeing to that. We're also seeing that patients, we need to be, or clinicians need to be helping a lot of our primary care physicians out. We're clinicians are really turning into more of a gatekeeper a lot of times for specialists and sending them to specialists, especially with like musculoskeletal issues and injuries. And so many times we look into evolution thinking that we have to be a complete expert as to be able to begin utilizing anything. But I think that's not necessarily true, that we have to be able to be a complete expert in this in order to find a use for it in clinical practice. Because right now we know modern day practice requires efficiency, it requires expertise, and it requires us to challenge ourselves and push our industry in order to stay within our scope. And our scope continues to evolve. You know, having real-time ultrasound feedback, again, it evolves and helps our clinical decision making. Does it change every scenario? No. That's with anything that we learn. Does it actually change every specific thing? No. But will it enhance it? Very much so. And does it actually help change and help answer questions for the patient and maybe make our clinical decision quicker? I see that every week. And a lot of times just calming down some like patient fears, patient anxieties. Again, another tool for not just education, but just kind of biofeedback and training. Just this last week, I was able to use it and actually demonstrate to patients because some patients want to see when I was actually doing dry needling placement, you know, in the back of the leg. So I can actually educate them on structures I'm staying away from, the areas that I feel like I need to be treating. And one that just lowered their anxiety and their pain sensitivity just by seeing what and knowing that I'm actually using kind of a guided tool with shockwave, extracorporeal shockwave, treating plantar fasciopathy or like a lateral hip tendinopathy in the glute med, understanding accuracy of tissue depth. So that way I'm using a correct spacer for that. That just enhances the practice. And now I'm actually able to watch tissue healing and tissue growth in like a lateral epicondylitis that maybe have like a tendon tear or again, a lateral hip, or watching inflammation of a thickened plantar fascia begin to decrease. Sometimes you'll find that again, patient compliance with just understanding where their part in exercise and their treatment, they get a little bit more buy-in with that. And I find that that's kind of what the practice demands today. It demands for us to kind of evolve with it and stay within our practice. And I'll talk in just a little bit more in a couple more slides of just like how do we actually bridge the gap to becoming more educated on how to utilize that. But first, let's just talk about how we're attempting to kind of bridge that gap first, kind of in an academic setting. What have we learned? What strategies
Ooh.
Oh, we lost Chris there.
Well, if we can advance the slide, I can jump in there. See, I think he had the control, but I'll take, there we go, advance it to the next
There.
one. We get him back on.
Yeah.
There we go. He'll come back as he's frozen. There he's back. There we are. So,
Yeah.
how do you develop competence? And where do we start? Sort of, Dr. Wolfe was just setting us up with this. And I think there's two fundamental skills, and it goes without saying because it's pretty straightforward. One, they have to have the ability to acquire a quality image. That's a skill set, a hands-on skill set we have to sort of work with. And then the second skill set would be to how to properly interpret those images in the context of the physical therapy exam and evaluation. And so for us, when we start this, and I don't think there's any right or wrong way with this, but we sort of integrate MSK ultrasound training during the second year of our program. We're a 3-year program, but 2.5 years of didactic training. And so throughout the entire second year, as soon as they come in, so the second year students will be coming in next week with this, and we have, Chris and I have them whole year for orthopedics. We've integrated MSK imaging into threaded throughout the entire year with this. And after they get an introduction in the fundamentals of image acquisition and interpretation, then we integrate this sort of vertically throughout the curriculum going forward. Now, for us, it was easy to integrate with orthopedics. And so as we go through regional assessments, shoulder, elbow, wrist, hand, whatever the case is, we have a segment built in to that with, after they've done the hands-on examination piece, we come right back in with MSK ultrasound, and we actually look at the structures again that they just assessed. So again, it's not done in isolation. We're doing everything in combination, put it all together, just like it is in the real world with this. So it allows for this seamless integration, I guess, between assessment and imaging assessment with this. And as we go through the process, we've identified competencies at each of these regions of the body that we go through. And through blended learning with our lectures, so our theoretical or didactic lectures, and then the hands-on experience. And as they do the hands-on experience, I think, Shelley, as you were here during the lab and got to see us going through it, the students actually go through, identify structures. They actually have to take pictures or grab an image of those structures. And then to close the loop with us to make sure that they're grasping material and able to interpret it appropriately. These images that they've grasped and saved, they have to label them for us, properly label them, and then submit those to us to look at. And then we keep working with them through the process. Now, I know some of you are out there watching and you're thinking, man, that's a big task to take on with some of these students. I'll tell you what my biggest surprise on us is we've adapted this into our curriculum. The biggest surprise to me was how fast the students grasp the process. I think obviously when we go through the fundamentals and they learn about the physics and all this, that's new material to them. But the actual hands-on application was unbelievably quick for these students when they were able to identify. And I think it's just an application of the anatomy. Personally, if I could design this a little differently in our curriculum, I think it would be a great adjunct. And for others that are listening, thinking about how do I put this in the curriculum and do things, I think it's a great adjunct to do with anatomy, with gross anatomy. They're learning gross anatomy, they're learning muscle, tendon, ligament, capsule, they're learning all these structures. It's a great way to incorporate this with palpation skills and to see it in real time, because obviously we can see dynamics with this and do it. And then if you've got it with the anatomy level or coming in with anatomy, which is a basic skill of the educational curriculums, now you can vertically integrate this in multiple classes across the board. So again, we can improve on what we're doing, but we have roughly about 30 hours of this in our curriculum where they're going through and specifically identifying, walking through these structures as we learn regional assessment with that. Now, Chris can talk a little bit more about some of the innovation that we do with this.
Yeah, I think the educational innovation side that Mike was just kind of talking about in a lot of detail there. Now we're just looking for like active learning opportunities for the students, because that's really what it takes in the clinical setting too. So we are finding that obviously a blended learning works the best. You know, they need more than just straight, just lecture didactic education. It's such a heavy hand skill. Unless you're actually practicing with it and utilizing it and knowing it, you're not going to become proficient at it and understanding what it actually means in relation to your clinical exam as well. And our students are learning a clinical exam for the first time, and they're practicing on one another. So they're not even working with real patients yet. And so it's a perfect time to combine like our online theory, our didactic information, and then with that hands-on practical session. So there's kind of like our blended learning opportunity. And then working in groups, okay? So like their group learning opportunity to kind of educate one another, peer teaching. So educating each other on like, this is the technique that I've been practicing. Let me help you understand this one. Now you help me understand your technique. Working together to kind of label tissues, pathological tissues and healthy tissues. We spend more time on healthy tissues because, just like when you're trying to figure out like a counterfeit bill, you spend more time looking at the real thing as opposed to counterfeit, because once you look at real tissue, the pathology will then begin to kind of jump out at you. And we spend more time looking at that, but we provide a lot of educational opportunity to visualize pathological tissue, tendon tear, tendon thickness from like tendinopathies and stuff of that nature, swelling in and around a joint or a bursa sac. The learning platform. So we're excited about every year we're seeing companies stay on the forefront of making their platforms more interactive. They're bridging the gap for us to make it so much more easily accessible for students and clinicians and educators to learn outside of the classroom on our own, and learn different scanning techniques, different patient positions and sitting or sideline or prone or supine, making it more efficient, more effective, because once you practice this, knowing as how to toggle the transducer one way or another can merely make an image look totally different. So we really promote our students actively looking at learning platforms. We provide that. We build assessments around their ability to interact with them as well. And then the greatest thing is now utilizing AI. AI is being built in everything. It's being built into Google. It's being built into every search engine. But now we're actually using it clinically to help compile information, normative data, looking at like what does tissue need to look like, and being able to utilize that now has really helped to improve our students' ability to learn what true tissue looks like. Learning grayscale for the first time. What does tissue look like, whether it's anechoic dark versus hyperechoic bright versus a blended version. Now that you actually have an AI model running side by side in real time, I've seen a lot of light bulb moments go off for students. In fact, that's what they say. A light bulb went off for me understanding tissue depth, or understanding the overlay, or understanding why this active assessment or special test does what it's supposed to, or what telling us, or why it doesn't. So staying and honestly working with a platform that provides that has really made our job a lot easier and really more fun in educating, again, just incorporating anatomy with clinical assessment as well. One thing that we have started to do, we did this about 2 years ago, I think, roughly,
Yeah.
really just to kind of challenge and help ourselves learn as educators and as practitioners. Because the best way to learn material, and this is what we tell our students all the time, the best way to learn material is to teach, to be held to the act of teaching somebody. And so Mike and I collaborate with a couple other professors and clinicians monthly to write an abstract of a how to scan a certain body area. We go from upper quarter to lower quarter. We try to alternate, but it really challenges us to dig into the research, understand certain scanning techniques, and then we find pathological techniques as well. We actually collaborate with a couple physicians here in Nashville that help provide pathological scans for us, so we can look at that and put that in the journal as well. But this was one thing that we wanted to do in order to have an abstract out there for learning clinicians, learning students, and academics as well. We use this actually in our program every semester. It's turned into part of our own curriculum, and we wanted to be able to provide that, be able to kind of help those in the clinic or those in an academic setting to learn, another platform to learn. But really, we're watching, a lot of the ultrasound platforms stay way ahead of us with offering so many good intuitive interfaces, so many good YouTube channel, good scanning techniques. So I really just find that the excuse of not having access to really to educational really is just limited by your own imagination or limited by your own search ability, because that gap is definitely being closed off. And then being able to watch it progress over the next couple months is really, really exciting. And watching our students, actually, sometimes they learn more things than we are actually teaching them. Because as Mike was saying, we've been so impressed with their ability to kind of grasp a hold of it and run with it. And I think we're seeing that through younger clinicians now in the clinical setting. They're finding great uses for this. Um, and I think Mike is going to talk
Yeah.
about now just how to, when we're looking for adopting a system, what things do we need to actually consider along with a platform that kind of works with us.
Yeah, I think that's important, Chris, and to these platforms. And again, this is just sort of a global thing. I says, beyond didactic, what do you need? Because didactic, we have our slides, and there's resources all over the world, really, for didactic education. With a computer and internet, we can pretty much find anything. The UK has a consortium on accreditation. The European Union has different educational things. There's one in the Netherlands. There's all kinds around the world. It's not just the United States or places like that. Worldwide, we can find all kinds of education that's open source to do it. Having said that, as we've said already, it's a difference between being didactic and clinical. This is a hands-on tool, but as I said before, the learning curve is pretty quick. So beyond that didactic component, we basically need a device. You need a qualified instructor, I suppose, if we're teaching somebody this. You need the student, and you need either a live or simulated patient, because there are systems out there that we use in our labs that's simulated for pathology and looking at this. From that, I think it comes down to looking at the different tools and what equipment are you going to need. And I think it's not just based on cost. I know while that in budget planning, that's got to be a big piece of this. We are very lucky here, and we probably should have, I didn't even think of it with Dr. Wolfe as we started today. We should have probably started off at the beginning and put a disclosure out there to begin with that we're not employees of Clarius. We don't work for Clarius. We're independent professors. We teach and use a lot of things. And in fact, Shelley saw this, but in our labs, we have various forms of equipment that we use to various types of equipment that we use. But I think what you need to look at, especially if you're adopting this in education, getting started here, is selecting the right equipment. And I don't think it's just the equipment. You're partnering with a company. I'm partnering with a company. It's people you want to work with that provides those things that Dr. Wolfe was just talking to, the platform that goes with it. We started off, quite honestly, we used Butterfly to begin with. There was a cost-effective way to get in, but we realized quickly we needed more things for our needs for our education. And I'm going to give Shelley a shameless plug with this for the company. But we did our homework. We looked at a lot of different companies. We tried a lot of different equipment when we went and looked at to see what's going to give us the best long-term solution for what we're doing. And again, I have my hand right here. I've got shows up my little Clarius unit. But we like Clarius because of not only the quality of the picture, but the learning platform. The things like we're doing today. A lot of the things because Clarius is doing to try to give us this educational platform of these things that we can look at to learn. There's technical features we need to look at. One that's not on our bullet point here that probably was a big thing people should look at when you're looking at it, especially if you're trying to incorporate this in education. What's the battery life of these handheld devices? As we were testing various companies, they ranged anywhere from an hour to down to 20 minutes, and they would die. Fortunately, we have ability to plug our devices in, and literally our labs go 4 hours, and our devices are not a problem at all, that we can go the whole time with a handheld on that. And then, as we said, the educational values of what kind of support are we going to get with these companies. And again, getting on the platform and looking at the things that these manufacturers provide us, there's no reason to not a reason to say that knowledge is a problem. The knowledge is out there. We just have to get out and practice. It's a hands-on skill set, but the learning curve is quick. And I think as far as budget planning, there's a lot of things we can do. And again, could we afford to jump in and buy 30 units right off the bat? Well, the medical school could when we first started. But in our curriculum, what we did when we started, we just said, hey, we think this is important to our curriculum. We know our budget's limited, but hey, can we just add a couple units a year? Can we just start to add and start to turn them over? And our students work in groups of 3 to 4, because one of them is always going to be a patient as they go through it. We don't have a problem with that. So I think getting started with system selection is that partnership that you have with manufacturers. And I think we have, Chris, and there we throw back, but we talk about it, what we think's important, and as the ones that started, and we're excited about it. But I think we got a recording we can show and we have this in our residencies as well. We have orthopedic and sports residencies, and our residents are fully immersed into MSK ultrasound as well. But I think we got a short video we can show what our residents think, and these are just freshly exposed.
You can see exactly what you're dealing with, so you kind of skip the guessing process, especially from like visit to visit, you're able to see more change. I think the impact of like having diagnostic ultrasound is huge.
It'd be extremely valuable to have that kind of interaction with your patients and telling them, this is the structure I'm concerned about, being able to visibly show them and say, this is why you're getting the shoulder pain. I think that gives the patient a sense of buy-in and a lot of trust in you. They'll be very confident in your ability to treat them down the line too.
They learned how to do some dry needling with ultrasounds. One, you can get a little bit harder to reach places, or maybe needle in places that you want to be more careful with, whether that's like the vascular supply or nerve supply, and you just don't want to mess with any of those structures. So using the ultrasound just gives me the confidence that I'm actually hitting the structures that I'm intending to hit.
One of the biggest barriers to people like not using the ultrasound is they haven't had the time or spent the time to deep dive and really learn it. So I think having the option to have the T-mode and have like the layout of what exactly you're looking at, I think a lot more people will be more apt to use it and they'll learn it a lot faster.
The first time you learn ultrasound, it can be a little intimidating because you see just all these different imaging and you don't really know what to make of it. But for anyone that's learning for the first time, if they just have that little thing that tells them, all right, this is what each structure is, this is where you're oriented right now, I think that would make the learning process a lot easier, and that would translate really well into diagnosis.
I personally wish I had it when I was learning it, and I think the students that are learning it now and being able to watch them use it in real time and just how much quicker they were able to identify different structures, I think would go a long way in terms of like long-term being like more precise when you're doing the diagnostic ultrasound. And I think in clinics, clinicians would be more amped to use it, having like real-time things to guide them. I think having MSK AI with physical therapists in practice, it will be used a lot more. I think you're going to be able to see exactly like that measurement of that tendon and then compare that across like the spectrum. You'll know if your treatment's actually being effective, and so you're just able to better have a treatment approach that's more specific and individualized to each patient.
I think the Clarius intelligence feature has shaped and will continue to shape the way that we're able to teach MSK ultrasound to students in the future, just with helping kind of catch them up to speed quicker with the improved visual of the anatomic structures, and then also it decreases the amount of time like waiting around the classroom for maybe a professor or a resident to come around and confirm the structures. They actually get the ability to do that in real time right there, which I think is phenomenal and will allow everyone to accomplish more during our learning sessions.
That's like being a proud parent right there watching that.
It was.
President Chris and I were smiling. I was watching you, Chris, to see that. And for those that are watching today, that was a snippet of what goes on in our laboratory when we're doing it. Those were filmed during the lab sessions with that. But when we have multiple things with students talking, but the residents had been exposed previously that you just saw there, but they learned it, and you can see their excitement in this. I'll just say one thing as I tee it up for Shelley to move forward and give us a little demonstration, is that as Chris alluded to, and you saw it in the videos going through this new T-mode with artificial intelligence coming in and helping with interpretation, that is a game changer. But it's a blessing and a curse the way I kind of look at it. I know Shelley and I talked about this, or anybody that's done ultrasound for a while. I know how I learned. I had to look at grayscales and try to figure all this out. I can
Polar bear. We used to call it polar bears in the snow, Mike. It was like that's what it looked like to me when I first started.
Exactly. A Rorschach test. We're looking at how it's going. When we go with the T-mode, as we're going to see now, and you're going to demonstrate for people, that is a game changer with students. Because what we do with it, and you saw in the video, and you'll see it coming up, the students can look at grayscale imaging of an anatomical part, and again, kudos to Clarius, because I think you guys are kind of the foremost leaders in this area of integration of diagnostics with this. But it is a game changer as far as diagnostics, that they can now see exactly what we're looking at, or it'll be labeled, as we're going to show with it. So when I say blessing and a curse, that's a blessing, because they are going to learn quicker and do it. It's a curse, I guess, that I wished I'd had it when I was starting years ago. The learning curve would have been a lot quicker.
All right. Good. I am going to make my way over and just give everybody a live demo here. And I know we had a couple of questions in the Q&A about what these models look like. So the first one I'm going to show you is it's called MSK AI. So I'm going to just select the knee preset, and I'm using the L7 scanner here. And I'm just going to pop the scanner over the region of the patellar tendon. And I like this feature. It's really nice to be able to not only identify the tendon, but perform a measurement really quickly. So what I'll do is I'll just go and turn on the AI, the MSK AI, and you can see that the AI highlights the tendon for us. We can increase the opacity of that if we like. So it just really outlines that tendon really nicely, and it would highlight kind of any thickening a little bit better as well. And then you'll see that when I hit the freeze button, it's going to place calipers over the thickest part of that tendon. So I think for serial exams, if you see a patient today with a tendon that's measuring this, and then they come back in a week or two after therapy, and they can see the difference. They can see that what they're doing is having an effect on the tendon thickness. I think that's you're going to get better buy-in from your patients that way. So we have MSK AI for a couple of different tendons in the body: the Achilles, the patellar tendon, and the plantar fascia, and they all work very similarly. So I will just remove the MSK AI here. And while we're in the same area, what we can do is turn on the T mode, which we've all been talking about here. So a little T icon down here at the bottom, and I'm going to pop that on, and you'll see a real-time graphical representation of the anatomy over on this side of the screen. And so it updates in real time. So as I move, we can see the entire length of that tendon. If I move to the top of the knee as well, I can see that as well. And then when we hit the freeze button, this is where we're going to get our actual labels. And so that will just kind of confirm what you're seeing. So you can see that, this could be a really helpful tool when you're learning. It also works in transverse. So, if I turn in transverse, I can see my patellar tendon there in the middle. And again, when I freeze, we can get our nice labels. So as a learning tool, very, very helpful. The other thing I can do is move over to the medial knee, and we can kind of, again, the palpation skills of the physical therapy students is unbelievable. But yeah, so I mean, they just palpate the medial knee here, and again, we turn on the T mode, and we're getting a real-time updated image. And then again, when I freeze, we can see the labels here. So pretty slick. You can save those images as well. And again, just really important to notice that it updates it for you in real time. And then if we want to go back to 2D, we can go back this way. Now, I'm just going to show you one more T-mode model. And we've just released this, not to the public yet, but it's coming soon. Sorry, my cold gel here. I'm going to just go to a new preset that we have that's called abdominal wall. And this is kind of geared toward physical therapy students, as well as plastic surgery people who are wanting to know the different layers of the abdominal wall. And I'm just going to decrease my depth here a little bit. And so there, we're getting a pretty nice image. But if we're just learning, maybe we're not quite sure where one layer ends and one layer begins. So if we pop the T mode on again, we can see the different tissue layers as well as the abdominal cavity here. But if I want to be sure, I can just hit the freeze button, and that's going to label all of those lateral abdominal wall muscles. And again, you could do this in sagittal or transverse, wherever you happen to be. So I'm looking in sagittal now on Mike's lateral abdomen. And again, we'll get our nice labels here. Now, from a physical therapy standpoint, if I wanted to look at rectus muscles and just get an idea of maybe diastasis rectus, if we were looking at a patient that had that and we were not quite sure where the muscles begin and where the muscles end, we can just bring up our T mode. And again, that's going to give us some graphical representations over here. I can just decrease my depth a bit just to make that a little bit prettier. And again, when we hit freeze, we can get nice labels here of the rectus muscle, the linea alba, and surrounding tissues. So then if you wanted to perform a measurement over here, you would be sure where you're measuring. I'll just go right to the midline here. We can get a nice, better idea of that linea alba. So lots of great tools. We also, there's T mode for the shoulder, for the anterior shoulder as well. And like I said, we've got some MSK AI that's available for different tendons in the lower limbs. So great. All right, I will head back to my little station here.
Great job, Shelley.
Thank you.
I think everybody can see now why I sort of said that, sort of teeing it up for you, how students find that immensely popular and useful.
Oh, and it was very rewarding to see the looks on your students' faces when they first popped up the T mode for the knee, because we had just come out with it. And I was like a proud parent.
It's probably second only to the look that Chris and I had when we first saw it with that doing, this is crazy.
Yeah, it was really good. All righty. Okay, so yeah, very exciting, the T mode. And like I said, we're developing new models as we speak. We want to continue educating and spreading the love. So yeah, we'll stay tuned to see what's up in the coming months. The goal is to make ultrasound less intimidating for everyone. So yeah, just before we open the floor to questions here, here's a quick poll for you. We'd love to help everybody continue their journey into bringing ultrasound into their practices or educational institutions. So please complete the poll if you'd like any additional information, and you can click on as many as apply. And while you complete this poll, I'd like to just take a minute to tell you a little bit more about Clarius HD3 scanners for musculoskeletal imaging. Clarius offers several options: 3 linear scanners at different frequencies and a lower frequency curved array scanner to meet your individual needs. So you no longer need a bulky, expensive ultrasound system that's complex to learn if you're ready to add ultrasound to your practice or your education program. And miniaturization and innovation means high definition imaging is now easy and affordable, with image quality that rivals traditional ultrasound systems, but at a fraction of the cost. You're looking at probably about an 85% savings. And with a new Clarius power fan, you can keep your scanner cool so you can scan for extended periods. And this is extremely valuable where you'll be losing your scanner in scanning labs or for complex procedures. With best-in-class high-definition imaging of the skin, muscles, tendons, and bones, you'll gain confidence in your patient assessments and accurately guide needle procedures for better treatment outcomes. Clarius uses traditional ultrasound crystal technology, which when paired with artificial intelligence results in really nice image quality without complex knobs and buttons, making scanning so much easier. Clarius is also wireless, freeing up space with zero footprint, which you saw in the presentation. Lends itself very well to teaching environments. It's fully immersible and so much faster to clean and disinfect as well. Clarius delivers wireless scanners with an ecosystem that includes a free app for your iOS or Android device and free updates when they become available. And available with our membership or one-time license, Clarius Cloud allows you to easily capture and manage unlimited exams from anywhere. Your membership also includes in-app classroom videos, and with ultrasound experts, your membership includes in-app classroom videos with ultrasound experts like our guest today, as well as onboarding with a Clarius clinical specialist to build up your ultrasound scanning skills. And also included with your membership are AI-powered features to automate workflows like MSK AI, median nerve AI, and T-mode, which I demonstrated for you today. And membership also includes several anatomy-specific imaging presets and measurements. So we'll now take a couple of seconds here to close the poll. Thank you for participating, and we'll get back to you in the coming week. Now, one more thing I want to just tell you about before we get to your questions, that we'd like to invite you to pre-register for an MSK webinar in early December. I know it's a ways off. The topic is going to be around ultrasound of the hip, and it'll be presented by ultrasound expert Mark Schmitz from Sonoskills. As many of you know, Mark's presentations are pretty amazing, and hip ultrasound is something that's been requested by many of you. So we couldn't think of anyone better to dive into hip scanning than Mark. So yeah, please, you can register now or anytime between now and December. All right, so let's get your questions. My questions are small. I have to put my glasses on. Let's see here. How many questions? So we've got quite a few here. All right. A couple of comments. Yeah, and there's a question about T-mode available for the vet field. It's funny, we have vet people watching the video today. All I can say is you're going to have to stay tuned. There was a question, let's see, lots of product type questions here, which I can answer later. There's a question here. It says, please speak to your experience with other body parts, such as hip and even spine.
Well, I'll start. I can start on that one and tee it up for the December webinar. My exposure to MSK ultrasound started with the hip. My clinical practice is involved in a very much niche hip preservation practice. And just as from not me, but I work with a nurse practitioner, Beth Bardowski, who's a wizard when it comes to ultrasound. In fact, we just had a kind of a milestone in that she just surpassed her 20,000th injection, ultrasound guided injection at the hip. We use, I think Chris was alluding to this early on, we use ultrasound daily within the hip clinic. And in fact, it's certainly reduced our reliance on other ancillary imaging tools such as MRI. We still get MR on certain things, but we can get a precise answer right away with ultrasound. So with other body parts, we use it for a lot of things. I know, Chris, you use it every day in clinical practice, and you got a more broad-based one than mine. I'm pigeonholed right into the hip, but you got other exposure with it.
Yeah, I guess to answer this question for hip and spine, I definitely use it a lot more for hip than for spine. For spine, usually I'm looking at just identifying like multifidus in like the cervical spine or the lumbar spine. We teach a dry needling course here as well, and so we are excited to kind of utilize it to help teach safety measures. Safety measures of just kind of like dry needling around like the lung space, definitely kind of like the thoracic spine. And so most of the time it's just utilized to kind of observe some of the musculature around like the erector spinae and the multifidus. The hip, definitely a lot, anterior hip, lateral hip, posterior, not just from like an assessment perspective, from a treatment as well, quite a bit.
There's a question here about pelvic floor scanning. Do you guys do that or teach it?
No, I'm not a pelvic floor expert and therapist. I've worked with several. In fact, I had one that was one of our former residents here, former resident, worked with me closely in the clinic, is a pelvic floor expert. And I've learned so much of how they utilize it, not just from like understanding like hypertonicity and versus like hypotonicity, like pelvic floor contraction, the biofeedback portion of it. I've watched people learn that super quickly. So if that's like an interest for somebody, I don't, utilizing it from those two categories of training, pelvic floor like contraction or being able to relaxation, that is actually pretty easy to learn, which is also nice too. Now the transabdominal assessment provided. I mean, we're usually teaching that in accordance with pelvic floor as well. But no, I don't work specifically with that population, so I don't find myself working in that range there. But I would say stay tuned very soon as
Yeah.
well.
I mean, it's
We,
definitely applicable. It's just, I think that the way to couch the answer from Dr. Wolfe and myself is we're blessed in that we're surrounded by some experts. That's an area that I think definitely needs to be addressed, especially working around hip. I'm lucky that we have somebody we refer to all the time that we use that uses ultrasound in their practice, just like Chris was alluding to. So while I don't do it directly, there's a definite application.
Yeah, and I'll just add that just a couple of months ago, we, for the person who asked the question about pelvic floor scanning, we did host a webinar on pelvic floor physiotherapy. And so if you want to go to our website and just sign up to watch that, the recording of that video, the presenter had some really good information and some really good imaging and showed how you can image the pelvic floor and her different techniques. So yeah, I would invite you to go and watch that. Great. So there's a question here about affordable, like the pricing of our scanners. And if you just go to our website, www.clarius.com, you can follow the links to the pricing pages, and it will vary depending on your location. So just make sure that you filter for your area. There's a question here about what model you would feel is best for ultrasounding the hip.
Well, out of the Clarius models, we'll use a C3 curve linear to get to deeper tissue. So, and that'd be the same thing in our clinical side, our clinical models we use. It's a curve linear. So C3 would be the one that I use for hip, for mainly do that. Although I will say my L7 that I got right here, L7 does give me some pretty good images around the hip, but the C3 will give me a greater depth.
Yeah, it just depends on the size of your patient too, right? I mean, if and the field of view that you want. Yeah.
Yes.
All right. Is it a must to use sterile gel when using with dry needling?
Highly recommended, not a must. The reason why is because we're not creating a sterile field. When we do dry needling, we don't create we create a clean field, but not a sterile field. So best practice, most ultrasound gel is clean, but when I do teach it, we do provide sterile gel. When I do it in the clinic, I use sterile gel. And so that's just kind of like a recommended best practice. But as soon as you open it and put it right smack dab on someone's like non-sterile leg, it's no longer sterile at that point. So again, clean technique is best practice.
Thanks. There was a question about, I have a question. Ultrasound is used in physiotherapy clinic, and is there evidence base? Can either of you answer that? I'm not quite sure what she's asking there.
Not sure where that's going. Chris, you got an idea where that?
So if we're definitely using it in the physical therapy clinic practice,
Yeah,
evidence-based, definitely so. I mean, there's copious amounts of literature out there for scanning and sonography and looking at normative data for like tissue pathologies as well. And so all of that is heavily researched and pretty accessible, easy to find as well. That's one reason why we're incorporating a lot of that into the journal articles as well. Looking at like what's proper tissue look like, and then what's pathological tissue like, and then we cite and reference all of that.
Yeah, looking at Shelley's polar bears.
Yeah.
Polar bears again.
Exactly. All right. Well, we are about at the top of the hour now. There's several more questions about product and integration and things like that I will follow up with following the webinar. Just a reminder that you'll all receive a video or an email with a link to the recording as well as the slides. So please complete our closing surveys to provide your feedback. And yeah, to conclude, I'd like to thank you so much, Mike and Chris, for your very enthusiastic insights. Thank you so much for inviting us into your lab. We had a blast, and it was very rewarding. And a very big thank you to all of you for joining us. Have a wonderful day and keep scanning.
Thanks, Shelley.